There's several chest CT protocols. Today we're going to focus on four of the most common: CT angiogram of the chest pulmonary embolism protocol, CT angiogram of the thoracic aorta, CT chest with contrast, and chest without contrast. The PE study is an early arterial phase. We wait 12 seconds after injecting contrast before imaging. 12 seconds is approximate. Most scanners will have a system in which they look at the pulmonary artery, track the opacification, and then trigger the scan right at the moment where it's best. That gives us good opacification of the pulmonary artery and ultimate sensitivity for looking for pulmonary embolisms. CTA of the thoracic aorta is slightly different. For this, we include a non-contrast phase. Reason being is that some findings associated with dissection or acute injury of the aorta are easier to see on non-contrast imaging. Here's an example. This is a case of an intramural hematoma of the ascending aorta, and it's best seen on the non-contrast phase. It's this hyperdense crescent in the wall. You can see once you've given contrast, it's actually harder to see that. It doesn't stand out quite as well. When we do the arterial phase for our thoracic aorta, we wait slightly longer compared to the pulmonary arteries just because it takes a little bit longer for the contrast to get there. Note that the pulmonary arteries may or may not be very well opacified with this protocol. It's common that we'll be asked to evaluate for pulmonary embolism on one of these thoracic aorta scans. Oftentimes we're not able to say one way or another just because the contrast timing isn't very good. Chest with contrast, we wait a little bit longer for this. This is your typical protocol used to evaluate lymph nodes, cancer if you're looking for metastatic disease or if you're evaluating lung cancer, and then complex infections such as abscess. I call it a portal venous phase. It's about the same time as the portal venous phase in the abdomen. Obviously here we're not evaluating the portal vein. It's just a delay that we're evaluating things like the lymph nodes and for any signs of abscess or other complicated infection. Here on the right you can see there's a patient with pneumonia who developed an abscess here, and it has that nice peripheral enhancement. We're able to see that very well in the portal venous phase. CT chest without contrast is very commonly ordered for pulmonary nodule follow-up. Pulmonary nodules are small. All we're looking for really is change in size or morphology, and so we don't need contrast for that. Cancer screening is a developing application, getting more and more common. That does not require contrast. And then if we're looking at lung fibrosis or interstitial lung disease, we also do not need contrast. So I think the take-home points are, for every study, think about, do I need contrast? And if you're looking for nodules or fibrosis, the answer is no. And then what structures do I want to visualize? Do I want my contrast in the pulmonary arteries or in the thoracic aorta?